Thank you, Professor Lee. He explained very well for real situation of Seoul National University Bundang Hospital, which is designated a hospital from our government. Especially last slide is very touching because every healthcare professionals are fighting at the front line. Especially the nurse with a bandage on her face is really touching for me. So thank you for all speakers for your excellent talks and sharing your experiences. There are so many questions on the board and also even in our email. So I would try to deal as many as questions as possible. First, I want to start with Professor Dong-hyun Kim, who is epidemiologist. So there are questions because I think maybe many nations are still before epidemic situation. So they're asking that, like Taiwan or Hong Kong, and the strong blockage strategy for foreign influx is still the most effective or very important. And can you briefly touch on the current efforts of Korean situation for blocking the foreign influx?
네, 질문 고맙습니다. 이 해외로부터 들어오는 이 감염자에 대한 차단과 관련된 이슈는 우리 그 한국에서도 문제가 된 바 있습니다. 그 홍콩이나 이제 타이완 같이 이제 시티 스테이트 또 작은 국가에서는 초기에 좀 차단의 효과가 관찰이 되고 있죠.
Just like other countries around the world, Korea also experienced problems from the foreign arrivals.
And he also mentioned that like Taiwan or Hong Kong is kind of city levels of small countries, blocking down the strategy for the initial period of foreign influx might be very effective.
근데 이제 이제 미국이나 이제 유럽의 일부 국가들은 이제 초기에 차단했음에도 불구하고 그 자국 내 전파를 효과적으로 이제 관리하지 못했다는 점에서 볼 때 이런 보드 클로즈가 얼마나 효과적인가에 대해서는 좀 리뷰가 필요한 상황이라고 볼 수가 있습니다. WHO의 International Health Regulation에 따르면 이제 보드 클로즈를 레코멘드 하고는 있지 않는 걸로 알고 있습니다.
United States and states in Europe enforced the initial blockage strategy, but as WHO advised, initial blocking strategy needs to be reviewed and seems to be not very effective.
최근에 그 한국 상황을 좀 말씀을 드리자면, 초기에 이제 보드 클로즈를 하지 않았지만, 3월 중순 이후서부터 이제 미국이나 유럽 쪽에서 환자 발생이 많아지고, 그들 나라에서 입국하는 인커밍 패신저의 상당수가 또 공항에서 그리고 귀국 후에 환자로 이제 밝혀지고 있는 이제 판명되고 있는 상황이었기 때문에 지금은 우리 이제 공항에서의 통상적인 레귤러한 체크업에 더해서 스페셜 애플리케이션을 셀룰러 폰에 깔아서 귀국 후에 이들의 14일, 2주 동안의 클리니컬 컨디션을 방역 당국에서 퍼블릭 헬스 에이전시에서 모니터링 할 수 있게 하고 있고요. 4월 들어서부터는 공항에서의 검역에서 놓칠 수 있는 환자들이 있을 수 있기 때문에 이제 무증상 환자들이 이제 들어오고 그런 것이 이제 우리나라 이제 방역에 이제 부담이 되고 있기 때문에 지금은 모든 해외로부터 들어온 입국자들에 대해서는 14일 자가 격리, 홈 쿼런틴을 실시하고 있습니다.
Starting from mid-March, Korean government required all passengers from United States to install cell phone application to track their health conditions. And starting from April, Korean government also enforced the 14-day home quarantine.
Yes, if the patient is symptomatic at the airport, we did a direct test at the airport, but if they are asymptomatic, maybe going home and recommend self-quarantine at least 14 days. And then after April, every passengers should be checked up this kind of the quarantine process, from my understanding. So the second question is maybe they are very curious about our tracing system. So they're asking that how many days you did tracing back for the close contact personnel, and what is the definition of a close contact personnel in Korea?
예, 이 부분은 그 기준 자체가 언제서부터 그 트레이싱을 할 건지, 그러니까 트레이싱이라고 하면 확진된 환자가 어디를 돌아다녔는지를 이제 체크하는 그 과정이 되는데요. 이 코비드 19에 대한 그 좀 생물학적인 이해가 시간이 가면서 점점 많아지면서 이 기준도 좀 변해왔습니다. 되게 일반적인 이런 이제 감염병 질환들은 증상이 발생하면서 전파가 이루어지기 때문에 처음에는 이제 심톰 onset서부터 마일드하더라도 심톰 onset서부터 추적을 했는데 초기 저널에 나온 게 이제 심톰 하루 전서부터 전파가 가능하다는 얘기가 나왔고, 또 최근에는 이제 심톰 발생 이틀 전서부터 전파가 가능하지 않겠느냐라고 하는 그런 사이언티픽 저널의 레포트가 있었기 때문에 지금 우리 한국 방역 당국에서는 심톰 발생 이틀 전서부터 이 환자의 동선, whereabouts를 체크를 하고 있고요. 이렇게 확진된 환자들하고 접촉한 사람들에 대해서 특히 이제 밀접 접촉자, close contact에 대해서는 우리가 한국 방역 당국에서는 14일간의 자가 격리를 명령을 하고 있습니다. 그런데 이 밀접 접촉자의 기준은 사실 이 조사를 하는 역학조사관 EIS 오피셜가 한테 주어진 아주 디테일한 가이드라인이 있지만, 실제로는 이게 퍼스널 인터뷰를 통해서 얻어진 정보에 근거해서 EIS 오피셜 역학조사관의 판단에 따라서 이 14일간의 격리를 하는 밀접 접촉을 정의를 하고 있습니다. 그러니까 예를 들면 가까운 거리에서 대화를 한다든지 그 상황에서도 마스크를 썼느냐 안 썼느냐에 따라서 또 기준이 달라지게 되고요. 식사를 같이 했다거나, 가족 같은 경우는 당연히 밀접 접촉자로 분류가 되고 있고, 그 다음에 이제 실내 공간에서 같이 일하는 사람들은 다 해당이 된다고 볼 수가 있고, 같은 청에 있는 사람들도 되고요. 특히 이제 우리 같은 경우는 좀 신천지 교인이라든지 이제 구로 콜센터와 같이 좀 특수한 경우에는 그 건물 전체에 있는 사람들, 그 집단 전체에 대한 전수조사까지 한 바가 있습니다.
Okay, the tracing back strategy has been changed. Initially, maybe the day of a symptom, the onset day of symptom, they have to be investigated. But there's many scientific reports that the stage before the symptom onset, like 2 days before, they can spread virus widely. So that's why we are tracing back around 2 days for their moving path. And about the definition of close contact personnel is really hard to make any decision, but we have very intensive interview with the person who got close contact, and the EIS official had decided that who is the close contact personnel, and the mandatory 14 days of self-quarantine is recommended. And for example, there's some person who had a very close conversation or the dinner or lunch together in a closed spaces. And also there's family members and other special situation like a religious facility or some closed call center facility. We are actually doing a lot of tracing back entire the building. So yes. And number 3, the question is very tricky because I saw many articles from European countries about the blaming our system, about the privacy. So there are we are very revealing the moving path and everything about the COVID-19 positive people, but there are some countries who are really caring about their privacy. So the question is how we can overcome those kind of privacy issues for monitoring those kind of massive revealing the information.
Yes, yeah. 우리나라에서 그 환자의 동선을 그 이제 공개를 하고 있습니다. 이 동선 공개를 이제 법적인 기반 법에 근거해서 하고 있는데 이런 법이 만들어진 건 2015년도에 이제 메르스 때 우리가 굉장히 큰 아웃브레이크가 있었습니다. 메르스 때. 근데 이제 그 당시에 그 증상이 있는 환자들이 그 여러 의료기관을 이제 1차 의료기관을 방문을 하고 거기 이제 진료하는 의사들을 감염을 시키고 이렇게 했는데 그 당시에 이제 이런 정보가 공개가 되지 않음으로 인해서 이제 의료인들도 감염이 되고 그 의료기관을 방문한 환자들도 감염이 되고 이런 이제 문제들이 있어서 이런 그 이제 감염성 질환이 발생했을 때 환자들에 대한 그 인터뷰와 조사와 또 이제 그 동선 공개가 이제 법적 기반을 마련했고요. 이번에 이제 코비드-19 아웃브레이크에서 이제 이런 그 이제 활동이 이런 이제 조사가 광범위하게 진행이 됐는데 일단 그 감염의 확산을 막고 또 그러니까 확산을 막는다는 측면에서만 보면 이와 같은 동선 공개가 효과적이었던 것으로 보입니다. 그리고 그 지역에 갔던 사람들로 하여금 그 환자가 방문했던 그 공간에 대한 방문했던 다른 사람들이 이제 그 필요에 따라서 또 추가적인 검사를 증상이 나타나면 이제 검사를 받게 할 수도 있었고요. 근데 이제 그 이제 프라이버시와 관련된 이슈는 여전히 좀 고민스러운 문제라고 할 수 있습니다. 근데 그래서 효과적인 측면하고 이제 프라이버시 프로텍션과 관련한 윤리적인 측면하고의 좀 트레이드 오프가 있기 때문에 이 부분은 우리나라에서도 계속 좀 고민을 해야 될 문제이긴 한데 불필요한 unnecessary한 정보의 공개에 대해서는 분명히 좀 문제가 있었다라고 생각을 합니다. 예를 들면 성이나 연령 같은 정보는 필요가 없는데 그게 좀 지나치게 공개된 면이 있다라고 생각을 하고 있습니다.
Okay, we have a very serious experience from MERS cases in 2015. So there are many patients visited primary clinics and they infected many physicians and many other patients. So because of that one, we make legal background to permit those kind of exposure of the information to the public. But still, the focusing on the strategy to blocking down the infection might be those kind of revealing the moving path is very important to prohibit the virus spread, but still have a lot of issues for the privacy. So he mentioned about that especially for the age or sex, which is not the necessary information for to the public. So still we are trying to making a nice balance between the privacy and the infection control aspect, from my understanding. Okay, Professor Lee, I want to ask about how do you manage COVID-19 positive but asymptomatic cases? You mentioned about the community health care center, which is operated by the Bundang Hospital and also the Gyeonggi province.
So yes.
Yeah, and also the what is the standards for the discharge? Okay.
So now since Korea has implemented this mass screening process, we have actually identified a lot of asymptomatic patient or mild patient. So what we do is that if patient is asymptomatic but has high risk, such as high blood pressure or other comorbidities, we are putting these people into this community treatment center for monitoring and treatment. The other is that so there are a lot of patients coming to hospitalized because COVID-19, and to lessen the burden when patients are clinically stable after treatment for COVID-19, and we move those patients to this facility so that they can unburden the hospital, but still we can monitor this patient in our facility until their vital status is negative. So that's the strategy for us to manage COVID-19, but who are asymptomatic. What are the standards for discharge? So for now, this discharge criteria is this. So we take 2 samples, nasopharynx also, as well as sputum as well. And then if those 2 tests are negative consecutively, and that there has to be more than 24-hour distance. So if patient tests negative for once, for both specimen, and after more than 24 hours, they do tests again. And if this test comes out negative again, and that's when the patient will be discharged.
Okay, so you showed the slide about the telemedicine things is temporarily approved right now. So do you think it's effective to monitor those kind of asymptomatic patients with telemedicine? And also there is some kind of questionnaire about the psychological status of those kind of patients, right?
Yes, so I think so far it's working pretty well because patients have mild symptoms and they're not, under critical condition. So just talking to a doctor and getting professional consultation is working very well. So especially as just Dr. Choi mentioned, because it's COVID-19 and this prolonged quarantine, it's in fact a lot of patients having actual complaining about mental stress. So what we do is that if patient complains of these symptoms, they can sit down at the on-site of community treatment center, and they can directly talk to our specialty in the Seoul National University Bundang Hospital. I think I showed the slide where there is operating center and also the command center, and a doctor all actually consulting with the patient. So whenever there is special need, patient can directly talk to our specialty in our hospital.
Okay, thank you. Let's move to the clinical parts of the question. So Professor Kim, recently there are big issues about the virus reactivation. So there are some kind of reinfection or reactivation and many other theories. Can you comment on its clinical implication and treatment method or strategy for those kind of patients?
Okay, so these issues has been raised in our country, also in other countries. According to the Korea CDC report, about 2.1% of patients have tested positive again for the virus after negative confirmation at least twice. We don't have enough information about clinical meaning or pathophysiology yet, but there are several explanations for this phenomenon. First, some non-viable viral particles can be detected in very sensitive PCR tests, and this is the most advocated by many clinicians. Other possible explanation would be reinfection by new virus or reactivation of the previous virus due to patient's defect of immune response to the virus. But when you check the patient's serum was in small numbers of patients, we still could find IgM antibody. When the Korea CDC performed viral culture for 6 patients, there was no viable virus cultured. There has been no secondary transmission cases of virus from the patients who have retested positive yet. We need more research for this phenomenon, but I think that mainly this is from the non-viable virus particle.
So might be close monitoring is important. For
Yeah,
those kind of
unfortunately, we have
cases.
no enough data for that, so we still have the same policy for quarantine. But after some more information, I think we can start the strong quarantine system for the second positive cases.
Okay. So, Dr. Lee, you want to add on some opinion for the reactivation of the virus?
그래서 이게 리액티베이션인지 이제 리인펙션인지 아니면 바이럴 파티클의 조각이 나오는 건지는 아직 저희가 정확한 데이터는 갖고 있지 않고요. 그런데 이제 다만 뭐 세 가지 가능성이 다 있는데 저는 리액티베이션 쪽에 조금 더 무게를 둡니다. 왜냐하면 환자들이 증상이 있기 때문이거든요. 환자가 전혀 증상이 없이 그 PCR에서 양성만 나온다면 당연히 뭐 그 바이럴 파티클이 일부 나오는 걸로 저희가 생각을 해볼 수가 있는데 환자들이 증상을 다시 보이면서 그 음전됐던 결과가 다시 양전, 포지티브 컨버전이 되는 거기 때문에 저는 리액티베이션이 조금 더 가능성이 있을 거라고 생각을 하고 이게 이제 이 바이러스의 특성 자체가 컨발레이선트 페이지가 굉장히 긴 걸로 보입니다. 그래서 회복기 자체가 워낙 길다 보니까 그 안에서 바이럴 플럭추에이션이 있는 걸로 생각이 되고 중국 같은 경우에는 대략 논문에 따라서 9에서 많은 기관에서 30%까지도 이런 사례들을 보고를 하고 있거든요. 그래서 바이러스의 특성에 의한 것들이 좀 많이 반영된 것이 아닐까라고 생각을 합니다.
Okay. He mentioned about the he thought the reactivation, the possibility of reactivation is much have more weight compared to other like remnant viral particles, because usually the patient is asymptomatic. So that's why the think about the characteristics of virus itself, and also the reactivation possibility is much high, and especially some areas from China, because Dr. Kim mentioned about around 2.1% in our Korean cases for the reactivation, but in Chinese case they reported 9 to 30% of reactivation cases has happened. So maybe we have to be very cautious and careful for this kind of reactivation issues. And second question for the clinical part is, can you tell more about detail for the treatment methodology? And especially there's a lot of question about the hydrochloroquine. I think maybe many countries had a hydrochloroquine or prescribe it easily, I think, other than antiviral agents. So please include other antiviral agents such as remdesivir and Calcetra or other experience of you.
Because our institute is a tertiary care hospital, so most of patients are transferred from other hospitals when the patient was getting worse in spite of antiviral treatment. So personally, I'm already pessimistic about the antiviral therapy, but we don't know about the real situation. So in my hospital, we don't use antiviral agent routinely in our institute. But we tried Calcetra or remdesivir in severe cases. When we prescribe this drug, we usually communicate with the patient about current knowledge gap and its limitation also. Unfortunately, we still don't know which agent is helpful or harmful to treat COVID-19 patient. There are some promising data about hydroxychloroquine and or azithromycin or remdesivir therapy recently, but it was not from well-designed randomized controlled trials with enough case numbers yet. Some concerns were also raised over potential toxicities of investigational use of these drugs, such as cardiac toxicity in hydroxychloroquine also. In case of convalescent plasma therapy, the effectiveness is still based on only several case reports. Therefore, we should admit the limitation of treatment options for COVID-19 now, and more data from adequately performed clinical studies are urgently needed. We are participating in the remdesivir randomized controlled trial sponsored by the US NIH now, and we are waiting for the interim result of remdesivir RHD of the study in May with some expectation.
In May, maybe we can see some RCT
Yeah, it's just
results.
interim report, but
Interim, okay.
Yeah.
And I've saw the journal from Severance Hospital that only 2 cases of passive plasma infusion therapy is very successful. So anybody can comment on the because Dr. Kim already mentioned about very experimental, but it's Dr. Lee from Severance Hospital. So can you comment on that one?
플라즈마 인젝션은 이제 저희 기관에서 트라이얼을 했었던 건데요. 사실 어떻게 짧게 문장으로 먼저 번역하시죠.
Severance Hospital conducted the past plasma therapy.
예, 이게 새로운 방법은 아니고 저희가 이제 노블 바이럴 인펙션이 있을 때는 시도를 해보는 방법입니다.
This is not a new treatment method. It's a method that we give it a shot when we have a novel coronavirus.
네, 저희 병원 같은 경우에는 그래서 2명에게 시도를 해봤고 그 2명의 경우에 있어서 이제 주목할 만한 증상의 완화를 보여서 시도해볼 가치가 있다고 생각은 하고 있고요.
We tried this method to the 2 patients in our hospital, and we've observed some great improvements in their symptoms. So we think it's very promising treatment.
Were there family members or just a separate?
Separate, as I know, the separate
Okay,
members.
the separate individual.
예, 그다음에 WHO의 그 치료에 대한 인포데믹스에서도 이제 질병 리포지셔닝 다음에 지금 트라이얼을 하는 게 사실은 이런 혈장 치료, 플라즈마 인젝션이고 그 다음이 백신이거든요. 그래서 분명히 시도해볼 가치는 있는데 이거를 어떤 대상군에게 어떻게 채취해서 주어질지에 대해서는 표준화가 좀 필요합니다.
WHO also recommends trying PBT, but there hasn't been any standardized therapeutic methodology, so we need some more study on this.
Right. Who will be the right indication for this kind of therapy, right? Okay. So let's move to our last question about the clinical parts. Because Dr. Kim is working for the chair of our infection control center in Bundang Hospital. So there are many caution about the many healthcare professionals got infected, especially in some countries. And can you mention about the in-hospital strategy for preventing in-hospital infection? Dr. Lee mentioned a little bit about the landscape, but could you can more detailed comment on that?
Okay, as Dr. Lee already mentioned, we have not experienced healthcare workers in hospital transmission, fortunately yet. We recommend all the healthcare workers to wear surgical masks universally during working inside hospital always. N95 respirator-based personal or protective equipment are recommended for the high-risk healthcare workers who are taking care of suspected or confirmed COVID-19 patients or who perform aerosol-generating procedures. We have also trained and monitored healthcare workers for adequate don and doff PPE also in high-risk wards. Every healthcare worker at risk area are monitored for febrile illness or respiratory symptoms daily, and PCR test and self-quarantine at home is strongly recommended until the result of the test is feasible, usually within 12 hours. We believe that the risk of transmission for healthcare workers in hospital is very low if they use PPE properly. Preemptive isolation and test for suspected COVID-19 patient is also very important to protect our healthcare workers. But there are some limitations to protect our healthcare workers from the community also. So basic measures is very important.
I think it's very hard. Dr. Lee, can you briefly add on that, because we have a positive workers in outpatient clinic, and then we had a massive trace back with close contact personnel. So can you talk about that one?
Yes. I'd like just to introduce the in-hospital transfer case of actually the other hospital in Korea. This hospital has more than 2,000 beds. It's a huge hospital. So what happened was that there is a 9-year-old patient who admitted through ER and needed urgent procedures. Since she had a history of visiting a hospital which is locked down because of COVID-19 break, she had a testing at ER. At that point, she does not have any symptoms, and the test was actually negative. So she moved into the hospital, she got tested and admitted to a ward. But after 3 or 4 days, she still has some mild fever, so they tested again. But unfortunately, the test came positive. So what the hospital did was that they quarantined the ward, and also they followed all the trajectory from the beginning. The ER, the testing room, the corridors where the patient passed, and then the hospital identified all the possible contact people in the hospital. So I think they tested about 500
yes.
people, and luckily they all were negative. And close contact, about 50 healthcare professionals were actually quarantined for 14 days, even if they were having negative test results. So there was no further transmission. And as far as I know, to date, it's been already more than, I think, 2 weeks. And then I think there was only 2 more confirmed cases from the instance.
Okay, thank you. The last part is covering diagnostic test. There is a lot of question for the diagnostic test. Maybe we did a mass diagnostic screening test for our patients. So, Professor Lee, can you explain in more detail about the RT-PCR kit from Korea? Its specificity or accuracy of those kind of kit?
예, 한국에서 지금 사용 중인 그 RT-PCR 킷은 5종류가 있습니다.
Right now, Korea uses 5 kinds of RT-PCR test kits.
이 5종류의 키트를 승인하기 위해서 저희가 평가한 키트가 지금까지 한 25개 정도가 되는데요.
We evaluated 25 test kits to get these 5 test kits, which turned out to be successful.
네, 그 25개의 키트 중에서 그 임상 검체를 이용한 그 멀티센터 크로스 체크를 시행을 하고 거기에서 이 평가에 참여했던 모든 기관이 동일한 양성과 음성 결과를 보인 것만 지금 현재 승인을 하고 있습니다.
We conducted a clinical specimen cross check in the many most of the facilities and the
Yes, we tested as many clinical samples as possible in multiple centers, and if the test result is same positive and negative, and that kind of kits are only approved, right?
네. 그리고 그 승인된 키트의 경우에 있어서도 저희가 이제 그 모든 양성 결과와 음성 결과를 랩 서베일런스 시스템을 통해서 매일매일 그 수집을 하고 있고요. 그 다음에 그 결과에서 조금이라도 이상하면은 저희가 다시 또 크로스 체크를 시행을 하고 있습니다.
We also collect the lab surveillance results through the network, and we also double checks the results to see the reliability of each test kit.
그래서 현재까지 이제 저희가 쓰고 있는 키트들은 특히 이제 메인으로 쓰고 있는 2가지의 최초 승인을 받고 2번째 승인을 받았던 키트는 민감도와 특이도가 둘 다 95% 이상인 것으로 평가를 하고 있습니다.
So the initial 2 kits that South Korea currently use have more than 95% of sensitivity and specificity.
Okay, so that's very reliable. But there are so many questions about the price. So in some countries, actually, they are so expensive to doing RT-PCR. So can you explain about the price in our system?
가격은 현재 국내의 경우에 있어서 한 $20 정도 한 테스트당 시작은 되고 있는데 이제 거기에 따른 여러 가지 또 그 핵산 추출, 그러니까 그 nucleic acid extraction이라던가 또 이런 비용들이 들기 때문에요. 현재 국내에 지금 보험 수가는 대략 한 $60 정도로 지금 잡혀 있습니다.
The cost of RT-PCR currently conducted in Korea starts at $20, but because of the extra testing schemes, the price usually goes up to $60.
So only $60 we can doing RT-PCR. So maybe other countries are very envy for this kind of cheap system. And the second question is actually many countries are not available for doing RT-PCR. So there are many questions about the rapid kit using antibody system. So, as you mentioned in your lecture, it's not comparable to RT-PCR and the molecular diagnostic tools. But could you briefly comment on those kind of situation without RT-PCR facility?
그 코로나19, 그러니까 코비드-19은 그 감염 초기부터 굉장히 많은 양의 바이러스를 배출을 합니다. 그리고 그 바이러스를 배출하는 시점에 대략 한 3분의 1에서 절반 정도는 증상이 없는 상황이기 때문에 저희가 이러한 분자 진단을 하지 않고서 지금 현재 바이러스를 배출하고 있는 사람을 찾기는 되게 어려운 상황입니다.
COVID-19 has a characteristic that releases large amount of virus, but for a third of incubation period, the patients tends to have no symptoms at all. So without the use of RT-PCR, it's very hard to detect.
Yeah,
the
he said
infection.
around 30% is asymptomatic, so it's really hard to avoid RT-PCR test.
예, 그래서 하지만 이런 분자 진단 검사는 많은 국가에서 실행을 할 수가 없기 때문에요. 이 래피드 킷을 많이들 요청을 하시는데 이 래피드 킷은 가장 많은 지금 형태로 개발되고 있는 게 항체 검사, 안티바디 테스트 킷이 되겠고요.
But for most countries, don't have the capacity to conduct the RT-PCR test, so they conduct the antibody test instead.
네. 근데 이 안티바디라는 거는 저희가 감염 후 7일에서 14일 정도부터 이제 증가를 하기 때문에 현재까지는 나온 논문을 기준으로 했을 때 10일째에 IgM 안티바디 양성률이 50%가 안 됩니다.
The antibody development starts starting from 7th day to 14th day after the first onset of symptoms. So, but the development percentage of IgM is less than 50%.
그래서 이런 안티바디 테스트 킷이 적절한 민감도와 특이도를 보이는 시점은 14일, 2주가 지나서 보통 이제 적절한 민감도와 특이도를 보이는데 2주가 되게 되면 증상을 보이고 2주가 지나면 대부분은 더 이상 바이럴 쉐딩을 하지 않고 그 다음에 증상도 완화됐기 때문에 치료를 할 수 없는 시점이 되거든요. 그래서 에큐트한 스테이지의 환자를 찾아서 관리를 하거나 치료하는 목적으로 사실은 쓰기는 어렵습니다.
The antibody test starts showing reliable results after 14th day, but at that point it's already too late to start any other treatments. So it's not very clinically meaningful.
It's not very proper for the acute symptom.
하지만 이제 저희가 다른 용도로는 쓸 수가 있는데 어떤 경우냐면 이제 많은 국가에서는 이제 RT-PCR을 할 수가 없거든요. 그러면은 이제 어떤 식으로 이 안티바디 테스트 킷을 쓸 수 있냐면은 예를 들어 특정 지역에 발열 환자가 있으면 그러면 지나간 코비드-19이라 하더라도 그 지역의 발열의 원인이 코비드-19이라는 걸 알게 되면 그 지역 자체를 격리를 할 수가 있거든요. 그 다음에 그러한 특정한 스팟을 찾아서 거기에 제한된 리얼타임 PCR 역량을 집중을 하고 그래서 현재 지금 누가 액티브하게 바이러스를 배출하고 있는지를 찾으면 그러면은 저희가 매스 스크리닝은 안티바디로 하고 그 다음에 정확한 그 진단은 몰레큘러 어세이로 하는 보조적인 방법을 써볼 수는 있습니다. 이제 제한된 그 리얼타임 PCR 역량을 갖고 있는 국가에서는.
Yeah, okay. So there may be the little bit limited application for the antibody kit if some area is with unknown fever is prone. Maybe we can test those kind of antibody tests. Is the cause of the fever is COVID-19, and then finally had a focus on the RT-PCR facility for tracing the active positive patients, and in those kind of some kind of screening tool for the certain area with unknown fever, and then and the causes might be COVID-19 or not, and that kind of case is useful, right? Okay. And the final question, and the final not the least, can you say the accuracy of the specimen the nasal and the oropharyngeal and the sputum according to the disease stage.
아까 말씀드렸던 것처럼 저희가 이제 이 코비드-19의 바이럴 카이네틱스의 특징은 감염 초기부터 많은 양의 바이러스가 상기도, 그러니까 upper respiratory tract로 나온다는 데 있고요.
The COVID-19 has a characteristic that emits a large amount of virus from the upper respiratory tract.
그래서 초기에는 나조파링지얼 수압이나 오로파링지얼 수압이 둘 다 검사에 적절합니다.
So at the initial stage, nasopharyngeal swab and the oropharyngeal swabs are reliable source of tests.
그러나 이제 감염 후 5일 정도가 지나면은 그러면은 오로파링지얼 수압에서의 그 양성률이 떨어지기 시작을 해서 대략 한 9일에서 10일 정도 되면은 오로파링지얼 수압은 네거티브 컨버전이 됩니다.
After 5th day of the symptom onset, the reliability of oropharyngeal swab goes down because due to the negative conversion.
그리고 그 시점에 이제 호흡기 증상이 나타나는 경우가 많거든요. 그러면은 이제 그때부터는 스퓨툼이 나오게 되고 스퓨툼에서의 그 양성률이 올라갑니다.
By the time the patient tends to develop respiratory symptoms and the patient starts to have sputums, and we take the sputum and test it instead.
그래서 감염 후기에는 객담에서의 그 바이럴 로드가 그 NPS보다 나조파린저스보다 훨씬 높게 되고요. 그게 더 이제 지속이 되기 때문에 객담에서의 어떤 양성을 평가하는 게 도움이 됩니다.
So the early stage, maybe nasopharyngeal swab is accurate, but after 10 days or other respiratory symptoms happen, maybe the specimen from sputum is much more accurate. Yes, okay. So actually time is running out, so I think this is time for wrap up today's webinar. Special appreciation for 4 experts of their precious sharing. And thank our viewers for your active participation. I hope our experience and reaction strategy for COVID-19 infection will be very informative to you and want to make a nice application for your own situation. Thank you for joining us. And if you have more questions, please email us. And there's an email address, the down parts of the screen right now. So please have any questions about the webinar. Thank you for tuning in. Thank you very much.